That was good.
Oh, hey, Chris.
Hey Chuck, how are you?
I'm fantastic. How are you?
I'm good. I'm here in the office on the weekend. What could be better?
I see your office in the background. It looks nice and neat.
Yeah, it's there's been some shuffling in our department space, and I'm excited that you have now given me a window office. So thank you for that. All of Dr. Nunley's stuff is still in the drawer apparently, so I'll have to sort that out. But I see him with some frequency, so I'll talk to him about whether he wants his old ID badges.
I think he probably wants you to deliver his stuff to him, is what I think. Um, I am all out of sorts, almost beyond description, because it's now been 1 week since I've had my computer.
Wow.
I'm on a loaner. I'm one who lives on my computer, and it's really making me
What happened
crazy.
to your computer?
Well, Chris, I was at the hospital and I had my bag, and somehow some water got spilled in my bag. And
Oh,
I didn't recognize it initially and didn't recognize how much water got spilled in my bag. And then after I got done with surgery, I had a book in there that was waterlogged and the computer was a little wet. I thought it would dry out in 24 hours. I took off the back, which probably I shouldn't have done, but everything online said do that to dry it out. And now it's with the computer gods hopefully making it right.
are you supposed to put like if an iPhone gets wet, are you supposed to put it in like rice, like uncooked rice, and just dry
That
it out?
is, you are not supposed to do that. That is like, apparently that's the rumor mill or whatever, but don't do that.
Well,
To all our listeners,
I'm hoping that our esteemed guest will have some advice both on how to dry out your computer and how to maybe fix or reconstruct SL ligaments. But why don't you introduce our friend who's joining us? I'm sorry to hear about your computer first off, but
thank you. Thank you for your sympathy. Yeah, it's a really special day. We have an amazing guest. Um, Sanj Kakar is joining us from the Mayo Clinic. It's kind of like the Ohio State
no, actually,
University.
I've been told it is the world famous Mayo Clinic,
I
not the
apologize.
Mayo Clinic.
Anyways, Sanj is a friend for a long time. He is a football fan, and that's the soccer variety, although his team, Liverpool, is heading in the wrong direction. And we're really super excited about his joining and teaching us and bantering with us. So, Sanj, welcome.
Chuck, Chris, it's a real honor to be here. Finally, I've heard and seen so much about this wonderful podcast. I have the loops retainer that I think Chris kindly gave me. I think I took a few of those, and I love the fluorescent color. And if I'm a little bit distracted, you're right. We're 10 minutes into the new season, and so I'll be keeping an eye on the score. But hopefully, we'll do better than your team this year, Chuck. How's the water bottle? So Chuck was our visiting professor for our fellowship graduation, so we got him a water bottle and some socks to highlight to the world his soccer aficionado.
Yes, well, I have to be a little honest with you. I do love Chelsea, and I still follow them. I don't think my soccer, and I may annoy many people on the call, but you're not born an English Premier team fan if you are a United States citizen the way that you were born a Liverpool fan. And so our allegiances aren't quite so tight. And when my team sucks, I consider cheering for another team. So I don't know where I am. I love Chelsea. I'm grateful for the water bottle and socks, but I thought I should say the fandom's not the same. You probably know
Yeah, it was for me. It's family here, and then Liverpool Football Club right
that.
there, as you can see in the background.
Well, Sanj, thank you for mentioning those loop croquis because we actually need to order more because that is the most requested item I've ever encountered, more than anything else. And Sanj, I'm going to try to bring you a coveted limited edition upper hand coffee mug. I actually found one the other day in my house, still in the plastic wrap. Somehow my parents have two of them at their house. I don't know how that happened, but we will try to get you the mug.
Oh, I love that.
Rob Gray is one of our friends. He's been on the pod before, and he sent us a picture of him with Dr. Orbe, also another recent podcast guest, who drinking out of the mug. So I will try to get you one of those.
Yeah, that'd be great. Rob's a great guy. He was one of our fellows, and what an amazing human being.
Yeah, he is super fantastic, and I look forward to seeing everybody pretty soon at the Hand Society. which is going to be coming up in your backyard in Minneapolis. But Sanj, before we jump into the topic, I'd love to know a little bit more about your path and where you trained along the way. Clearly, your Texas accent is strong. So tell us a little bit about you and when you knew you wanted to be a hand surgeon.
Yeah, so it's an interesting question. So so I was born and raised in London and went to medical school, and medical school there is 5 years. And so after our first 2 years, you go into clinicals, but my best friends wanted to spend one more year and get a Bachelor of Science degree. And so I had a passion for anatomy, and it was a funny route. And so I met Professor McGrowther, who's was big into flexor tendon healing at the time, and my modules did not line up with the project that we were doing. So he said, do orthopedics. And I have to profess, I didn't even know what orthopedics meant. I saw the word ped in there, wasn't really interested in children. And I said, no, this is not for me. And so I obviously have to look at what it was. And so during that, I actually met Dr. Gelberman at the British Society for Surgery of the Hand, because he, as you know, is a thought leader in flexor tendon healing. And so I met him and really inspired me about the thoughts of academics in the United States. And then my mentor there in London were Professor McGrowther and Professor George Bentley. And so what I did, I asked them, where should I go? And they said, you need to go to Boston. And I said, well, do you know anybody in Boston? They go, no, we don't. But you need to go to Boston. That's where orthopedics is coming out from. So I literally wrote to everybody in the editorial board of JBJS. And back then, Chris, you probably weren't conceived at the time, but you had to send faxes. And so I sent faxes,
I
and
know what a fax is,
yeah,
and I
and
have
so
sent some faxes in the past.
and I thought the United States was like England. I thought I could go to Boston and then to LA and then to St. Louis and then be back in Boston at the same day. Had no idea how big the United States was. So I drew a ring around Boston, and then I basically literally packed my bags and visited people from Boston, New York, Philadelphia who answered the fax. Not everybody did. And I remember one day I was with this person called Andy Rosenberg, who's a bone pathologist at Mass General. And he's looking at me and he said, why are you here? I said, well, I want to do academic orthopedics. And he said, oh, I'm a bone pathologist. I just happen to be on the editorial board of JBGS. And he said, there's somebody called Tom Einhorn, who was the chair of orthopedics at Boston University at the time, giving grand rounds. And it's amazing how fate happens. I didn't plan to meet this person. He said, just go and see him. So as Dr. Einhorn was coming off the podium, leaving the auditorium, I gave him my CV, and then I went back to my hotel, and sure enough, he had called my mentors back in London, invited me to come to visit him the next day, and then the rest is history. And
That's
so
insane.
it is. It's kind of weird, and it's sort of my MO now for other people who want to try and come over. In that you had to try and take a risk. I didn't plan this, and so he said, I can bring you over, but I can't pay you. I can bring you over and you can do research for me in the lab for 1 year. So I went home, moved home with my parents, saved. I think I did the USMLEs in about 7 months because I didn't have those exams, and then came over and just loved it and met him and Paul Tornetta, who really sort of took me under their wing. And then I was fortunate to match there and then did my residency there. And yeah, it's funny how life turns out.
Wow. That is something. I think not a lot of those of us in medicine would call ourselves risk takers. I mean, some of the appeal as I talk to my children about kind of life choices and job paths, and my daughters are younger or in college, and they're a little jealous of my son who's on the medical path because it feels like his course is just plotted out safely. It's still with choices, but very safe. And your story is not that.
Yeah, I think there's an element of risk to it, but it was I told my parents because they had no idea. I was a PGY4 when I left London, and they had no idea. They go, "Why are you going over? You have to start over again." I had to sit the TOEFL, which is the test of English as a foreign language, to come to the US. They did not believe my birth certificate or passport at the time, and yeah, I said it was short-term pain for long-term gain.
You had to take the TOEFL coming from the UK.
I did.
That's
I did.
that.
And I nearly failed it because my mind was drifting. And they asked very specific questions like, Chuck Goldfarb went to Starbucks and ordered A, B, C, or D, or E, and so you had to actually listen
But
to pass it.
that is so American to make somebody from the country where our language originated take the test of English as a foreign language. Anyway, can you, that's amazing. And we talked a little bit about, your mentor, Dr. Tornetta. Did you have any other mentors along the way? And, what did they teach you? Is there anything particular that lessons they imparted upon you?
Oh, sure, Chris. Mentors evolve over time. I mean, when I was in Boston, honestly, when I was going through residency, the choice between spine and hand, and I was flip-flopping between both. And my hand mentors in Boston, Andy Stein, Eric Tolo, Alice Hunter, George Kasparian, I think Max Sung, and Steve Margles really took me under their wing and actually opened my eyes. I mean, to get a letter from Eric Tolo, he said, "Look, out of respect, can you go to my alma mater where I did my fellowship?" And so I came to Mayo, and if you've not been here before, I remember taking the shuttle bus, and it's an hour and a half of cornfields, and I'm like, I'm born and raised in London. I'm in Boston. Like, where have you sent me? And I'm texting him on the phone, like, and he goes, just wait till you get there. So, it's funny how mentors evolve. And so I think for me, my mentors in Boston were crucial for me. In England, actually, they were my most influential. I mentioned George Bentley and Professor McGrowther, but there was two others, Faris Haddad and Andy Williams. They're basically hip and knee surgeons, and I didn't look like the typical orthopedic surgeon in London at the time, and they really took me under their wing and sort of guided me through the process. And I'm always grateful to them. Every time I go home to London, I always try and look out for them. I think when I came to Mayo, my current partners have been amazing. And you learn from them over time. Dick Berger was very influential to me at the time. But then you meet others. And so, for example, Dr. Stern and Seitz, I met just at meetings. I'd never trained with them. I'd heard about them and how influential they were to others. And they just took time out of their day just to get to know me as a human being. And I'm always grateful for that. But then, there's other people, I served under Jim Chang in council, learned so much from him. Really did. I mean, what an influential person he's been previously and to me. And then people like Marty, Boyer, Jennifer, Wolfe, Tamar Rosenthal, and Scott Cozen. But that's just, domestically. I think I've learned a lot from people overseas. And my Bunnell, I think, really was eye-opening for me because I got to see other people really challenging dogma and pushing thoughts that I didn't even know was possible. I remember a story with PC Ho. He had a course in arthroscopy course in Hong Kong, and I remember sitting in the audience watching them about scaphoid non-unions. And I thought we had scaphoid non-unions sussed, as medial femoral condyle, vascularized bone grafting, and I saw him doing things through the scope that I didn't even knew were possible. I had great mentors in the US. Dick Berger, I mean, he's a forefather of arthroscopy. And that really sort of was a flip in my mind about the fact of seeing others outside of your bubble and then challenging that dogmatic aspect. So these mentors, I probably left out some, and I apologize for that, but these have been critical in my thought processes, previously and hopefully moving forward.
I think it's really easy to get caught in an echo chamber if you choose to surround yourself with people that have the same training and the same thought process. And I think that's amazing that your Bunnell Scholarship, which is awarded by the Hand Society to the elite in hand surgery, to travel and see, to go to places of your choosing. That's incredible. You had that opportunity. I wanted to get a little bit into the meat of our discussion, but before we do that, we do have to acknowledge our sponsor. The Upper Hand is sponsored by PracticeLink.com. The Practice Link is great at sponsoring people for finding positions. I was asked by a former fellow if I could do this copy in my sleep without showing it. I said, I don't know, but here's the copy. The Upper Hand is sponsored by Practice Link. Becoming a physician is hard. Finding a job doesn't have to be. Visit Practice Link at practicelink.com. I think that's it, but I'm
practicelink.com/ the upper hand.
There you go.
Uh,
Almost got it. Almost got it.
almost. Um, yeah, Sanj, the mentor discussion was super interesting, and obviously we could talk all day. Um, the briefly, I guess, how did the wrist, and maybe it was Dick Berger, excuse me, maybe it was Dick Berger's influence. How did the wrist become so important to you in your practice? And I guess that is interesting to me and in arthroscopy itself. And then we do want to dive into talking about the topic of the day, which is SL ligament pathology.
Yeah, it's a great question, Chuck. It's funny when I came here on staff, right? I did everything, and there was an area that nobody was doing, which was tumor. And so I remember speaking to Dick Berger at the time because he was the division chair, and he said, dive into tumor. And I found great mentors in Peter Jepson, Pete Murray, and Ed Athanasian, and I loved it. I loved taking care of those patients. But as a fellow, the wrist always fascinated me because we know so much and we know so little. And the irony of all of this is during residency, I really didn't do much arthroscopy whatsoever. I didn't even know you could put a camera in the wrist. And just watching somebody as elegant as Dick, and Dick was an amazing arthroscopist, even better human being, and an amazing artist. And he could sketch these things out. And it was just being here, being surrounded by my partners. There's a strong legacy of wrist at Mayo with Dobbins and Lynchide and Cooney. And so I think just from that aspect, that's where the passion really came from. And at the time, there was somebody, as you everybody knows well, was Mark Garcia Elias. And I remember listening to Mark's talks. He was so eloquent. His dissections were so perfect, and it was just something that sparked in my mind. But at the time, as a junior faculty, everyone was doing it, and it was hard to try and carve out that area. But I remember, Chris mentioned the Bunnell, and what an amazing opportunity that was. And for the Bunnell, as you know, you have to put a theme. And I wrote my first one about tumor. And somebody came up to me, it may have been Marty, I'm not sure. And he said, "Are you really passionate about tumor? Is that what you want to do for the next 20 to 30 years?" And it wasn't, and he just said, "Look, just stick to your passion and you'll see what will happen." And the rest is history.
I love that. I love that. And that's right. I mean, there's so many lessons from what you said. But finding your passion, passion may be hand surgery, but hopefully it's a little more than that. It's easy for us to say in academics where we're both blessed to have wonderful partners that can, take on other parts of the hand practice. But like you, I've been lucky to find my passion and narrow things down a little bit. Let's maybe we'll kick this off. We'll just briefly present a case, no images, just a theoretical case of a 32-year-old executive who is racing on his bicycle. We have a race in St. Louis called Race for the Cure, which has raised an incredible amount of money for cancer
I
research.
thought I thought you were going to talk about the naked bike parade, which was a couple of weeks ago. But yeah, that's fine. That's fine. No
Were
worries.
you were
Race for
you
the Cure
there?
is a better one. Yeah.
Were you there again, Chris? Do we got to keep you naked off
I
the bike?
I heard about it from a patient.
I heard about it. So you're on the bike at this really nice event that raises money, and unfortunately, you go flying over the handlebars, and the executive lands on his outstretched dominant right wrist, and he has immediate pain. It hurts a lot. It swells immediately, but he's able to get back on the bike, finish the race, and about a week later, his wrist is still hurting. He comes in, you get an X-ray and he has what for all the world appears to be a scapholunate ligament injury. There is 3 millimeters of diastasis between the scaphoid and the lunate, and the scaphoid is a bit flexed. The scapholunate angle is about 60 degrees. And so he comes in, you examine him. Why don't you, if you wouldn't mind, give us a couple of tips on how you do a physical exam if you're worried about scapholunate ligament pathology and sort of the thoughts that initially go through your head.
Sure. No, it's thanks for that sort of setup. Well, the main thing, we'll talk about the exam first, right? So for me, anything about the wrist, the beauty of the wrist is I think 95% of the diagnosis and the history and the physical exam. I think imaging we use to sort of rule in or rule out pathology, but I don't sort of hang my hat on it. So I think so. Just like finding the 3-4 portal, right? I find Lister's tubercle, just come distal to it, and there's a soft spot right there. And essentially, if a patient's tender in that area, there's 4 diagnoses in my mind. I mean, obviously, this is a traumatic case, but sometimes you see patients come in with chronic history of wrist pain. So it's either an occult ganglion, it's a scapholunate ligament injury, it's either some form of sort of scaphoid impaction or wrist impingement. So those are the 4 things that go through my mind on the physical exam. We use the sort of the shift test. Uh, I don't know how much stock I put into that test unless they maybe have some pain, but the clunking that you're so-called talked about, I don't often see, maybe pain with it, but not the clunking. And so typically I get,
Can
yeah,
I interrupt? It's a really interesting point because I also find the Watson scaphoid shift test to be potentially helpful, but not very specific and not very sensitive. And for those who haven't read about it, and we will use our video, this is a test where you start in ulnar deviation and slight extension, and you manipulate the wrist from that position to a position of slight flexion and radial deviation while putting pressure on the scaphoid tuberosity to theoretically prevent the scaphoid from flexing, with the theory that when you move to radial deviation, the scaphoid has to flex and you get a pop and pain dorsally if the test is positive. I hope that was helpful. It may not have been, but your point is right. I don't put a whole lot of stock in that test either. Chris, I don't know if you have thoughts about it or you use it regularly.
I use it all the time. I very carefully document whether the Watson test is positive or negative for pain, shift, or clunk. Because I think that the Watson positive negative gets thrown around. And there are 2 physical exam moves that I teach every resident or fellow when I have the chance. It's the Watson test and testing for ulnar nerve stability, because nobody knows how to actually do those tests when they come to clinic, except if they've rotated with Chuck. But I feel like those are 2 tests that oftentimes are not appropriately performed. And I didn't know how to do them until I really sat down and read the papers. But the Watson paper itself, and then really thought about the scaphoid, what you're trying to do with that maneuver. So oftentimes I will see it can produce some pain. It can have some shifting, but the full-on clunk when you release your thumb, I very rarely see.
and I'm going to give a shout out to Bill Kleiman. There's a video on Handy, which if people would know is a digital platform from the Hand Society. He's got a wonderful physical examination video on there. And it's funny we're talking about that, and maybe Chuck and Chris, we can collectively work on this together. But in my mind, there's a sign that when they come in, sometimes patients will say it feels like it's going through and through from the dorsal to the volar. I call it like the C sign because you're putting your fingers there. And I haven't proven it yet, and maybe you can guide us how to do it, and we can do it together. But I think that when they say that, to me, it's a through and through injury. It's dorsal to volar. And I found that in clinic and enough times now where patients will point dorsally and volarly and say, pain's not just dorsal, it goes through and through. And, when you scope them, it is a through and through injury. So those are the clinical signs that I use. And then typically I get an X-ray bilateral wrists because, as Chuck, in this case you mentioned, there's 3 millimeter gap. But as you know, there's a subset of populations that have 3 millimeter gap on the other side as well. So you have to correlate one with the other. We get actually PC Ho has a nice trick actually on the X-rays, because typically when you get an AP X-ray, you get an obliquogram through the scapholunate interval. You're not looking at perpendicular. So he recommends putting your ring and small finger and making a fist, and that actually bumps up the wrist. And so now typically I use his little trick of that gives you a collinear perpendicular view through the scapholunate interval. So I get that, and I get a stress view. Now, we were always taught about X-rays, and sometimes you can have dynamic scapholunate instability. But when I first started in practice, they would tender over the SL, they would have a normal stress view, and the MRI would be so-so. And then now what do I do with these? And where I found that when you scope these patients, just under half, like 41% with normal X-rays and tendon over this had Geisler 3 or 4 or high grade instability. So I just don't hang my hat just on the X-ray. It has to be with the clinical findings. When I look at the MRI, there's a couple of points I look at. I go through the axial view and the sagittal views, more important than the coronal views, because in the axial views, you can look at it if it's dorsal, if it's volar, if it's through and through. The sagittal views for me are helpful for looking at carpal alignment. So you talked about scaphoid flexion. Also, there could be scaphoid dorsal subluxation. And also the lunate, is it extended on the sagittal view, or is it only translocated on the coronal view? And I think we're learning more and more now about these dorsal extrinsic ligaments. So there's these, they were called secondary or critical stabilizers. For example, the DIC ligament, or the long radiolunate ligament, or the STT. My point is that an SL injury isn't just an SL injury. There's other things going on, and maybe dogmatically we were taught just address the SL and you'll be fine. As we know, that's not the case. And I think there's great work coming out of New York, out of Australia, just really teaching us about those other ligaments.
So I
So
wanted
I
to know a little bit more. I mean, you said so much in that last statement that I think people want to know more about. And I guess, what do you mean by a stress view? Because I've seen a couple different descriptions of how to get a stress view.
yeah.
And then, are you getting an arthrogram when you do an MRI? And then I want to talk a little bit more about, an SL is not an SL. We can talk about that afterwards, but let's talk about what a stress view is and whether you get an arthrogram.
Yeah, great point. So there's many stress views, right? And I think Steve Lee in New York showed the pencil grip view was the one to get. We typically get the clenched fist view. So true PA with the ring and small finger lying flat on the cassette will give you first of all the orthogonal view and then grip. And that's sort of the clenched fist view that we get here. We do not get an MRI arthrogram. Ours are just MRI 3T. I found that's geographical variation on the arthrograms that are performed, but we typically just get a standard MRI.
I like that. Yeah, I stopped doing orthograms a while back for a number of reasons. I do think they typically provide additional information, but they're not always easy. Patients don't love them, and I don't know the information we get is all that transformative. So I agree with that. I'm gonna have to look into the extended index and middle finger. I'm very curious about what that can do for us. So back to Chris's question. Talk to us a little bit, and I know you have a soccer game to watch, and Chris has a case to do, but talk to us a little bit about talk to us a little very basically about the scapholunate ligament itself and what is most critical for you, and the key accessory or critical ligaments, as you call them, supporting the scaphoid as well, and the principle that it's more than a SL ligament.
Yeah, so we were taught, right? So the SL ligament's a C-shaped ligament, dorsal membranous volar, the dorsal being the strongest and the volar being weaker than the dorsal, the membranous being the weakest. And I think historically, because of that, everyone pined to the dorsal SL. It's the strongest, but it never made sense to me. It's like a door coming off the hinges. If you fix it dorsally, it's going to gap open volarly if the volar structures are injured. So that's number one. But number two, these dorsal or critical stabilizers that of the dorsal intercarpal ligament dorsally, the long radiolunate ligament volarly, and the STT ligament, all of this complex may or may not get injured. It's a spectrum of injury. And I think if you look at it critically, when we've been doing these bigger open repairs, like what are we repairing? We're probably repairing the SL and maybe tacking down the dorsal intercarpal ligament, but we're neglecting the others. And so I think now through arthroscopy, and that's what's really sort of inspiring and challenging here, is I think we're learning things that have always been there, but we just didn't know about them. And so now, I mean, there's many times when I'm scoping these patients, I'm critically looking at all of these ligaments. So what am I looking at? I'm looking at the SL, I'm looking at the insertion of the DIC, which you can get an idea on the sagittal views and the MRI, but I confirm it arthroscopically. I'm looking at the long radiolunate ligament. I'm looking at the STT ligament and sort of going through that algorithmically about which ones are injured and which ones should we repair. Because sometimes you go in there and the volar SL is open, so you fix it volarly and you're done. You don't need to touch the dorsal SL. And so I think we haven't figured it out yet, but we're on our pathway to doing it. There was a good article recently by Scott Wolfe. There's two articles in Journal of Hand Surgery where he goes through this sort of ligament classification on which ones are injured. I don't think we've perfected how to fix them all yet, but we're getting there. And so for me, when I'm seeing a patient, I have an acronym in my mind because in the operating room, it's hard to have all these tables. So my acronym is SCARCE, right? So S is for the secondary or critical stabilizers. The C is the cartilage. Is it arthritic or not? If it's arthritic, you're not going to do anything, irrespective of the acuity of the injury. A is the alignment of the scaphoid on the sagittal view. Is it dorsally translated or not? Because that's a different beast. Is the lunate extended on the sagittal, or is it ulnar translocation? Again, that's different. The R is reducibility. Can I easily reduce the carpus? Because if I can't, any form of soft tissue reconstruction probably won't work. C is the chronicity. Is it acute or chronic? You painted an acute case, but we see many chronic cases that still can be repaired. And E is the extent of the injury. Is it dorsal? Is it volar? Is it through and through? What other ligaments are injured? And I think you have to package that all together to then be able to treat those. And for me, I mean, it'd be good to hear Chuck, you and Chris's thoughts. For me, the quality of the secondary stabilizers, the reducibility, the extent of the injury, and the location of the injury, for me, I can only detect arthroscopically. And so I make that final decision of how I'm going to treat these patients once I've done the scope.
Wow. I feel like you just dropped the mic. Like that was so much knowledge right there. I mean, that was like Steph Curry at the end of Team USA's game against France. I mean, that was amazing.
Hardly.
I
More like Steven Gerrard scoring the winner in the FA Cup final.
Right, that too, right, whatever that was. So I want to ask you some more questions about how you assess those ligaments
Yeah.
arthroscopically, and how you talk to patients about it. But before we do that, I did want to let our listeners know to mark their calendars for October 25 and 26 for Checkpoint Surgical's next cadaveric course, Upper Extremity Nerve Distress. Ooh, what a title. Strategies for Surgical Management. Join the course faculty, Dr. Fraser Leversedge and Dr. David Brogan, we know those guys, in Denver as they review management strategies for commonly encountered challenging nerve injuries and conditions affecting the upper extremities.
To learn more about this and other educational programs, please visit nervemaster.com. Checkpoint Surgical, driving innovation in nerve surgery. So yeah, so talk to us again briefly about how you place your scope to make determinations, and I'll get the ones that aren't obvious, I hope. Um, the long radial lunate, the volar SL, and the STT joint, which could include the DIC as well. Sort of how do you assess those four areas arthroscopically?
Okay, so great question. So the long radial ligament is assessed through the radiocarpal portal. So cameras in the 3-4 portal, probes coming in through the 6R. And sometimes you can see it's stretched out. Sometimes you can see it's actually coming off, partially injured off the radius. So you're using your probe and you're sort of trying to understand the natural tension of these. As you've shown, Chuck, with the TFCC, there's a high degree observer variability in this. And so we're learning, right? So this is a new sort of concept. So that's how we assess the long radial lunate ligament. Mid-carpal arthroscopy. So one pearl to the listeners. I always found getting in the mid-carpal joint challenging, really hard. And so a little pearl is that typically the dorsal ulnar structure on the wrist that's most readily palpable is the triquetrum. So just find the triquetrum, just go distal and radial to that, and that's the soft point for the mid-carpal ulnar portal. So I always make the middle carpal ulnar portal first, because if they have subtle degrees of scapholunate instability, the scaphoid flexes and moves distally, and it's harder to get it. And we were taught that the portal comes in like horizontally. Invariably, you're really dropping your hand to get in there. So I always make the ulnar mid-carpal portal first. It's easily to find, and then I make the radial mid-carpal. Then I put the probe in, and then I'm assessing the probe, putting it volarly to look at the volar SL, looking at dorsally as well. And then I'll drop my eyes and I'll look at the DIC insertion on the dorsum of the lunate. And I will take a probe and pull that off. Christoph Mathluin also talked about the DCSS, which is the insertion of the capsule essentially down onto the dorsum of the carpus, which you can assess dorsally from the radiocarpal or mid-carpal joint. I tend to find it easier to do from the mid-carpal joint. And then the STT, so I've got an idea of the STT from the MRI preoperatively in the sagittal view. And then what I'll do is I'll pop the camera in the radial mid-carpal portal you hug the scaphoid radially and you follow that up and you'll drop into the STT joint. It's harder to feel that arthroscopically looking at those ligaments because it's a very tight space. But I'll have a high index of suspicion if there's dorsal subluxation of the scaphoid and it flexes, has it rotated out of the STT? And Nick Smith in Sydney, Australia, has really sort of highlighted the importance of that.
That's amazing. That's a lot, and I think for it's probably a little daunting for some of our younger listeners to hear all that. I would say that um, that's incredible, and it highlights the complexity of the pathology we're discussing in a way that, I'll be honest, many people don't approach it in a similar way. There is a concept that I have my treatment for SL pathology, excuse me. And it's an open exploration and repair or internal brace or whatever. And yes, maybe there's a role for those procedures, but I think increasingly we're starting to understand that it's far more complex and you need to really understand the pathology to have a chance, just to have a chance to get to realign these patients. So that's great. And maybe what I'll do is just outline in this particular case, because we really want to know how you are going to surgically address it, and we could talk for hours about the different variables. But let's say there is a complete SL tear, so dorsal and volar, and don't really worry too much about membranous. And we'll say it includes a tear of the DIC, and the STT capsule is questionable after arthroscopy. So you're doing dry arthroscopy, which also for the listeners who don't do dry arthroscopy, it does make the actual scope part less influential for your open procedure. If you're doing a not dry arthroscopy, then you have to deal with a lot of water, but you're not dealing with that. So you've done your scope, you've come to the conclusion. What next?
Yeah, so Chuck, I'm just gonna, because to your listeners, as you say, right, they may think, wow, it takes me a long time to even get in the wrist, and then I have to look at all these ligaments. So how do you do this in 2 hours? So my algorithm in 2024, right, is, and then I'll get back to your patient, is I will say to the patient, we're going to do one of three things. In general, for scapholunate pathology, I'm going to scope you, and if you're arthritic, right, we're going to treat this as an arthritic wrist. And so the options are doing a partial denervation at the same time, or we're going to start, treating it with injections, blah, 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 and nurse you along. That's option one. Option two is I'm going to scope you. And if I find that you have these ligament injuries that on this case, then I'm going to fix you arthroscopically at the same time, plus or minus pinning. If I find that I get in there and what I'm trying to do arthroscopically, I cannot get it reduced, but you have a reducible, reconstructible problem, then we're coming back another day, we're closing up, and we're going to talk about open procedures, because open procedures, we can talk as you said, we can talk hours on this. There is morbidity associated with that procedure. And I think patients really need to understand that. And I think it's like when you're going in and say, I could do plan A, B, C, D, or E, you're not getting anything into your brain. And so I think for me, that's how I really sort of treat these patients going into the operating room. And also you can plan your surgical day, because if you're scoping and then you're going to open and then you're going to do a big reconstruction, that's a 2 to 3 hour operation right there. And when you have multiple other cases going on or two rooms, it's hard to sort of logistically plan it. So back to your patient. So
Let,
what
let,
I
let
would,
me let
yeah,
me interrupt for 1 second. I would just say that's really important, especially for the younger surgeons. And Chris and I talk a lot about flow in a day and efficiencies, and we don't talk a lot about coming back. And I encounter that for the exact scenario you discuss. I encounter it for elbow pathology, OCDs, for example, whether you're going to do a microfracture or an OATS. And so we shouldn't be afraid of coming back, even though no one wants to do that, patient or physician. But there is a place for it. And as the complexity of the injury goes up, patients have to understand that may be the right thing.
and Chuck, to your point, when I went overseas, I would see that all the time. If a patient was having a decision between scaphoid excision, four-corner fusion, or PRC, the surgeon popped the camera in, take pictures, stop, come back another day. And I was like, wow, you can do this? And he goes, why wouldn't you do this? It's more informed decision for the patient. So, it's learning from others, right? For what we could do today. So to your point, to that patient, it's acute, scope the patient, there's no arthritis, it's reproducible. So for me, Volarly, I'm repairing this. There's many ways to describe this as inside out or outside in, of doing a volar scapholunate arthroscopic repair. Dorsally, I think Christoph Mathluin has really popularized the repair of this DCSS, which I do. And when the DIC has come off the lunate, Mark Ross and Greg Cousins have popularized a procedure called the radical, where you're popping an anchor in the dorsal aspect of the lunate and tying the ligament complex down. And I don't hesitate to pin if I cannot reduce it. Like if I put the sutures in, there's days you'll put the sutures in, and I was a skeptic, trust me. I did not, I did the DCSS procedure that Christoph Mathlin described, didn't see anything, was very skeptical, saw him on the Benel, and he just said, get your camera ready, literally watch this. He put the suture in, pulled on the 3.0 PDS, and it reduced. And I immediately became from a doubter to a believer. And so technically I was doing something wrong. And so that's why I think, as you and Chris have said, going to see others, seeing how they do it is huge. I just technically couldn't get it from just reading a paper. And so now, if you put the sutures in and it reduces, which most will, especially in the scenario that you've done, that you described, then we're done. But if I'm pulling the suture and it sort of gets there, but it's not perfect, then I won't hesitate to pin them. Two SL, one scapha capitate. I cut the pins under the skin, leave them in the cast for 6 to 8 weeks, and then take the pins out. And I, knock on wood, I haven't regretted that sort of algorithm approach.
So Sanj, that's amazing. I mean, listening to you and Chuck talk about this is like listening to a master class. So for a not expert in this area, I have two questions before we bring it to a close. One, is there anything you can do on your pre-op assessment that can tell you whether the scapholunate deformity, for lack of a better term, whether it's diastasis, SL angulation, lunate dorsiflexion, is there anything you can do to tell whether it's reducible before you're in the OR? And then two is the SL really repairable?
Yeah, these are great questions. So, what you can do preoperatively, you can either get live fluoro, or what we have here is we just get motion series where they're taking sort of flexion extension views. And all I'm watching there is seeing, does the lunate reduce in its position? Does it move? Because sometimes it will. And in the case that Chuck presented, which was acute, it should, but sometimes it doesn't. But that doesn't necessarily mean that you can't repair them, because when you get in the OR, through the scope, you can debride all that scar tissue and you can make something that was partially or irreducible, reducible. Number two, to your point, I think with these repairs, these are more arthroscopic capsular DCs. You're not actually repairing the ligament. Like when you're doing the volar SL repair, you don't actually see the volar SL. You're repairing the radiuscapha capitate, which is attached to the scaphoid, and the long radiolunate ligament, which is attached to the lunate, and you're essentially bringing them together. And as you bring them together in an acute scenario, you're bringing that SL ligament together to repair. So I don't think you're actually technically repairing the ligament. You're repairing the capsule back down to its insertion.
And allowing the SL to reapproximate.
Yeah.
Wow, that's bomb. I love that. Thank you for joining us. We'll have to have you back to talk about all the open procedures and reconstruction because there's so much to unpack here. And Chuck, be excited. I picked an SL article for Journal Club on Monday for you, just for you.
I saw that. I am excited. Sanj, to put you on the spot a little bit, I'd love to include in our show notes a couple of resources for the listeners, whether that's a couple of key articles that you really find transformative, doesn't have to be 2024 by any stretch, and maybe a handy video or two, and we can certainly link the Kleinman video, just so people have a few resources. If you don't mind, that
Yeah.
would be super helpful for us.
Yeah, I think so. I think the articles to read right now are the two series articles by Scott Wolfe, I think in the last year in the Journal of Hand Surgery. These were review articles which goes through the anatomy and biomechanics and then the ligament type of injury. I think on Hand E, we talked about Bill Kleinman's video. I actually also put a physical exam video on there as well. And I think in terms of arthroscopy, there are several videos on wrist arthroscopy. Just first of all, understanding how to do this on Handy. So I would probably watch those wrist arthroscopy videos first. A sort of shout out to the Hand Society meeting coming up in September. We're doing an arthroscopy course, which is partnered by IWAS, which is the International Wrist Arthroscopy Society, where we'll be basically taking an A to Z approach through all of wrist arthroscopy. So it's a one-day Tuesday pre-course And I would just urge people to come and just even learn how to scope, because we're not really taught how to scope. There's a few centers, yours included, that really teach it, but most people aren't really doing much of this because we were never, Chuck, Chris, we were never taught this when we were training. So we're learning this as faculty, trying to sort of inspire the next generation. So that's probably what I would say right now.
Love it. Love it. Thank you. Good luck to Liverpool this morning, and hope your weekend is excellent.
Chuck, Chris, thank you so much. Really enjoyed this. What is it? About 50 minutes discussion. Just flew by. I mean, you two are just amazing at this sort of yin and yang approach. And I know this is a deliberate way. It doesn't happen by happenstance, but thank you so much. I really enjoyed it.
I'm glad it came across that way. All right. Thank you, Sanj. Really appreciate it.
Take
Cheers,
care. Thank,
boys.
thank you.
See you this